So hi, my name is Laeben Lester. It's a pleasure to get to talk to you today about the ABCs of procedural sedation in a high-risk patient and give you some strategies and ways of mitigating this risk. I do have one disclosure. We performed an internally funded randomized controls trial looking at the Supernova mask, and the company Vyaire, who now owns them, gave us the masks for that, and I will mention them in this talk. So in high-risk patients, our anesthetic matters because it affects the airway directly. So we need to avoid airway obstruction, and the medications that we give tend to cause a decreased neural output to the airway muscles and some direct motor inhibition of the muscles themselves. And related to this is a loss of the protective airway reflexes, and obviously, as you well know, these patients are at risk for aspiration. Breathing, which is inextricably related to the airway, is also affected, and hypoxia can be a major issue. And this is partly due to some decrease in changes in the respiratory drive, as well as motor weakness to the chest wall and diaphragm. And the position that we utilize during sedation, particularly being supine, can affect the lung function, as can atelectasis resulting from hypopnea, apnea, hypoventilation. And the circulation can be affected, as we just saw from Dr. Brady's talk and talked about in several of the talks yesterday. So one of the keys is to maintain our cardiac output and systemic vascular resistance in order to maintain coronary perfusion. So here's a case to consider. A 25-year-old woman with scleroderma. She has severe pulmonary hypertension. She's unable to eat because of difficulty swallowing, and they want to do an EGD. Her blood pressure is 105/72 with a map of 80, and her pulmonic side, her pressure is similar, 72/40 with a map of 55. So she's already relatively low in her systemic blood pressure. So what's the central tenet? And as Dr. Kostapos told us yesterday, preserving right ventricular function is the key to safely managing patients with pulmonary hypertension, okay? Clearly, avoiding hypoxia and hypercarbia, which affect the pulmonary vascular resistance, will help us. But preserving RV function is the key. So how do you do this? Well, you gotta be a little bit like Wayne Gretzky, who said, I skate to where the puck is going to be, not to where it's been, or something related to that. Okay, so this is key. So we'll talk a little about some of the risk factors for adverse events, and you know this intuitively from taking care of patients and from sitting through the lectures here now. But anything that affects the airway can make sedation and anesthesia more difficult. So things like sleep apnea, Mallampati or difficult airway risk factors, and even the anesthetic. Perhaps propofol may change your therapeutic window and affect this. Any pulmonary disease is going to put your breathing at risk, and any cardiovascular disease, and especially pulmonary hypertension, can put you at risk. Things like stroke can increase your risk as well, and there's nothing about obesity that makes sedation or airway management easier. Procedures involving the airway also make it more difficult, and so endoscopy, both ERCPs, EGDs, those can increase our risk. We have to share the airway. So fortunately, cardiac arrest is pretty rare, but it is not rare enough. In fact, in one study, and it is retrospective, up to 6 in 10,000 patients had a cardiac arrest. And importantly, this is airway related the most of the time, and we sort of know this intuitively, but this is some data to support it. You will note here that the fentanyl and midazolam group was actually a lot lower risk of cardiac arrest. This is retrospective data, so these are not necessarily the same group of patients. The patients that required anesthesia to be involved are often at higher risk or have more complicated procedures or already failed the other attempts. This was from the University of Pennsylvania, and it's retrospective, as I said. It was 5 years of data, but it was 73,000 patients. So one thing we can do is reduce the hypoxia rate, and most of us are already using capnography, but it does reduce the rate of hypoxia. In this meta-analysis, it reduced the rate of mild desaturations as well as more severe desaturations, and this data is corroborated by several other studies. But capnography is limited. In these cases where we don't necessarily have an endotracheal tube or an LMA, it really becomes nearly a qualitative measure. And here we see this decrease in the tracing. And usually in a sedation case, it's not because our cardiac output is completely dropped. It's usually because we have some partial obstruction, increased dead space ventilation. But the important point is that as your end-tidal CO2 decreases or your minute ventilation is decreasing, actually your PaCO2 is rising. So the take-home is that end-tidal CO2 is incredibly useful when we're doing sedation, but it is limited. In the future, I think we'll have some more better measures of minute ventilation and tidal volume. What else can we do? And I actually think this is incredibly important both in sedation and in inducing general anesthesia. Turns out the way we administer drugs, the rate and how we titrate them has a big effect on hypoxia, on breathing, and on circulation. In this study, they actually used different rates of induction of sedation, and they measured the time to loss of consciousness. And you can see when they used 500 mLs an hour, that it took about 86 seconds to induce loss of consciousness. And when they used 2,000 mLs per hour, it was only 32 seconds. You know this from anesthesia. But they had significantly higher rates of hypoxia, from 10% to 40%, and significant associations with hypotension as well. Let's translate it into doses that we generally use more frequently. So with propofol, given at a rate of 1 milligram per kilogram for a total dose with induction of about almost to 1.8 milligrams per kilogram, we see a 25% rate of apnea. But look, the apnea only lasted 10 seconds. Whereas when we use a higher dose, 4 milligrams per kilogram, we see that everybody gets apneic. And this duration of apnea is way longer, almost 250 seconds. So that's important to keep in mind. The rate at which we give medication and our total dose matters in terms of maintaining ventilation. So what are some things that we can do? Well, we can add other medications. So you're going to hear more and more about multimodal anesthesia, multimodal sedation. There was just an article that literally just came out in anesthesiology talking about this for anesthesia in general. But the addition of other medications, in this case we'll talk about ketamine, to a propofol-based anesthetic, and in this study they used midazolam and fentanyl as well. When we're doing high-risk patients, we generally don't give, depending on the procedure, an opioid as on top of it. But what did they find? And I think this graph just brings it home a little bit. Well, when they added ketamine, they had less effect on blood pressure. They had less effect on respiratory rate. In fact, it was higher. And they had less hypoxia. And there's several other studies that show similar results. Overall, they used significantly less propofol. So there is synergy with these medications, and you can get away with significantly less of the propofol when you're utilizing them. What else can we do to minimize hypoxia and maintain airway patency? Well, things like a nasal cannula or a nasal airway can be helpful. And in this German study, they actually placed a nasal airway and they hooked it up to the circuit with positive pressure and reduced their hypoxia rate from 13.5% to 2%, so an 11.5% reduction. But they did have a nearly 5% risk of mild complications, including things like epistaxis, which are never particularly fun when you're managing an airway. So this brings up the supernova that I mentioned before, and so far the only thing published in the literature are case reports. We have some data that we're working on now that we should be publishing soon. But this is a picture of the mask, and it's essentially a CPAP-like device that provides a seal. It can be hooked up to your anesthesia circuit and provide positive pressure, or you can use a Mapleson circuit. And here you can see on the top bar of the ventilator tracing is the change in pressure with respiration. So I think we're going to see this used more, this kind of positive pressure device or related ones used more frequently during sedation. This is a study looking at high flow nasal cannula, and in this study, what they did is they actually looked at high flow nasal cannula at 60 liters per minute on one arm, but with only an FiO2 of 40%. And they compared that to a nasal cannula at 4 liters per minute. And with that, high flow alone did not improve the decrease the rate of hypoxia. In fact, they're both around 40%. So pretty high rates of hypoxia. This was colonoscopies in obese patients, so they may have been slightly higher risk in that regard. But overall, with this fixed FiO2 that was pretty low, they didn't show any benefit. And actually, we have friends at Maryland doing a similar study, and I think they're going to have somewhat similar results with higher FiO2 levels. So high flow nasal cannula probably gives you about 3 centimeters of water of positive pressure, but it might be a little more that's required to overcome the collapsibility of the airway during sedation. So I think the other thing you're going to see down the road are devices like this supraglottic airway called the LMA, this one's from LMA, called the LMA Gastro, in which the endoscope can be placed through the supraglottic airway directly into the stomach. And also, there are cases in which the appropriate way to approach these is with general anesthesia with an endotracheal tube, particularly the patient who's bleeding severely. Now, just one more thing in terms of pulmonary hypertension is the transition from negative pressure respiration to positive pressure ventilation can have significant effects on the preload that can significantly alter the hemodynamics. One thing that I would plug for, and we don't have data to support this yet, is the idea of pre-oxygenation. And what I'm showing here is that the newer ventilators will give you an end-tidal FiO2. And when you get the end-tidal FiO2 above 90%, that is really a marker that you've adequately pre-oxygenated the patient, and so this is important in many aspects, but I utilize this in endoscopy cases to pre-oxygenate before placement of the endoscope, and it overcomes that initial coughing, which is sometimes associated with desaturation in the non-pre-oxygenated patient. If they're just getting a nasal cannula, they're not really getting highly pre-oxygenated. So let's get back to circulation, and how are we going to be like Wayne Gretzky? Well, we know that propofol and many other anesthetics are going to cause venodilation, affecting our preload, a decrease in myocardial contractility, a drop in our SVR, and often a lower heart rate, right? So we can plan for this. The result is hypotension and putting our coronary perfusion at risk. So what can we do? Well, we talked about giving the medications slower and more deliberately. We've talked a little bit about multimodal sedation and anesthesia, and I think we're going to hear a lot more about that in the future. But we can use a vasoconstrictor to maintain venous tone and SVR, and we can use inotropes to preserve our myocardial contractility and preserve our right ventricular function. Ultimately, this maintains our blood pressure and coronary perfusion and prevents the dreaded cardiac arrest. So in Our Lady with pulmonary hypertension, and who's a little nervous when they have a patient like this that they're planning for sedation or any anesthetic? It makes me actually really excited. But in this lady, 25-year-old woman with scleroderma, severe pulmonary hypertension, who's having difficulty swallowing, has already low systemic pressures and high pulmonary pressures. What do we need to do? The central tenet is to preserve the right ventricular function. Okay, so how are we going to do that? Well, in this case, actually, I would use standard monitors. There are sedation cases where I will put an A-line in, but in a scleroderma patient, that has its own slew of risks. So standard monitors cycling the cuff more frequently can be very useful. We want to maintain this patient breathing, and how can we do that? Well, we can do that by helping with a jaw thrust. We may consider pre-oxygenation before the procedure, but often I'll do this with a nasal cannula. Maybe I'll use one of these newer devices in the future. But I think the key point is to support that right ventricle. So I will start this patient on a drug with inotropic activity, usually epinephrine, sometimes norepinephrine, depending on what I want the heart rate to be, and usually at its starting dose 0.05 to 0.1, depending on where the patient's blood pressure is beforehand. I will also use bolus dosing as needed, and dopamine is a reasonable medication as well. For anesthetics, I will often use multimodal anesthesia. So I'll titrate in a little bit of midazolam. This younger patient, I'd probably give around 2 milligrams. And then ketamine around 0.3 to 0.6 milligrams per kilogram. So usually I'll titrate in 30 milligrams at the beginning, see where they're at. And for propofol, I'll give boluses, but they're small boluses, 10 to 20 milligrams at a time. Okay, and titrate slowly to effect. And I'll start my infusion at low dose, somewhere between 2.5 and 50 micrograms per kilogram per minute, depending on the patient. This younger patient, probably around 25 micrograms per kg per minute. We can always add more, okay? And in general, with this type of an anesthetic, we actually get a really nice plane of anesthesia, and the patients are awake within minutes of turning off this really low dose of propofol. Okay, so it can be very effective. And we're going to look at some of our data from these high-risk patients here shortly. So what did we talk about? We talked about the ABCs of sedation, and one of the things we want to do is reverse some of our airway obstruction that occurs, and we talked about a few methods for doing that, including positive pressure and pre-oxygenation. We talked a little bit about breathing and how that's sort of directly related to the airway in general, and the importance of avoiding hypoxia. And then we talked about making sure that we maintain our cardiac output in SVR to preserve the coronary perfusion. And if you do these things, you will be able to do these sedation cases successfully and well in the high-risk patient.